Hello, welcome to Sonography Radiology Training Channel. This series of videos is about fetal genitalia ultrasound. This is the second video in this video series with title of Fetal Sex Determination Part 2. The outline of this presentation include introduction, the anogenital distance, testicular descent, fetal scrotum and penile size, fetal retrovesical interspace, three-dimensional ultrasound, pitfalls in sonographic fetal sex determination, and final teaching points. At first, introduction. Overall, the accuracy of fetal sex determination in the second trimester ranges between 92 and 100%, which some studies believe that accuracy is higher for male gender, whereas in the others it's higher for females. Unlike first trimester sex determination based mainly on the visualization of the angle of the genital tubercle, second trimester fetal sex determination is based on actual visualization of the penis and scrotum in males and the labia majora and minora in females. In addition to visualization the external genitalia, there are other ultrasound findings enabling determination of fetal sex with an accuracy of about 100%. These include the anogenital distance, testicular descent, fetal scrotum and penile size, and fetal retrovesical interspace. At first, the anogenital distance. Anogenital distance refers to the length of the perineal area between the anus and genitals. As mentioned in video part 1, this distance is more in male fetuses than in female fetuses, and it's used as an item to determine the gender of the fetus in the late first and early second trimester. This difference still exists in the later stage of pregnancy, but the method of its measuring is different and has a different importance apart from determining the gender of the fetus. What is the measurements technique for the anogenital distance? At first, the anus is identified with its circular hypoechoic sphincter and with hyperechogenic mucosa in the center, famous as target sign. The distance is measured from the center of the anus to the posterior convergence of the vestibule or foreshead in female fetuses and to the posterior base of the scrotum in male fetuses. For this measurement to be taken, the fetus legs must be apart to accurately visualize the scrotum in males and foreshead in females. Measuring anogenital distance in 2D ultrasound scans has been shown to be feasible and reliable. According to some studies, this measure has the potential to aid in the early identifications or understanding of the pathogenesis of genitalia development, polycystic ovary syndrome, and anorectal and male genitalia malformation. Also, according to some studies, anogenital distance has been implicated as a predictor of androgen-related outcomes in later life, including reproductive outcomes. And also, according to some other studies, there is growing interest in whether it may also predict neurodevelopmental outcomes associated with elevated prenatal traits such as autism. The ability to reliably measure anogenital distance in utero shows this measure has potential to be introduced as part of a routine ultrasound scan. So a series of researchers have provided nomograms for it according to the gestational age, like this article which was published at 2014, and they provided nomograms for anogenital distance between 20 and 35 weeks of gestation in two separate tables for male fetuses and also in female fetuses. Also, other studies show that the anogenital distance continues to increase after birth and is correlated with birth weight, and the differences observed in the anogenital distance prenatally are maintained across an individual's lifespan. Testicular descent. At 25 weeks of gestation, about 30% of fetuses had at least one descended testis, which this percent increases with increasing gestational age, and by 32 weeks, bilateral testicular descent was observed in about 97% of cases. Fetal scrotum and penis size. This study constructed a centile chart of the fetal scrotal size that demonstrated that scrotal size increases with gestational age. Other studies showed normal penile length was found to increases with increasing gestational age. Of course, in normal fetuses, fetal scrotum and penis size are not needed to determine the fetal sex, but in cases of ambiguous genitalia, these items and nomograms will be very helpful. Fetal retrovesical interspace. The presence of the uterus in male fetuses results in an increased distance between the bladder and rectum compared to male fetuses. This study showed that measuring the distance between the posterior wall of the bladder and the anterior wall of the rectum allowed us to determine fetal sex correctly in about 99% of female fetuses and about 100% of male fetuses between 13 and 40 weeks of gestation. What is the measurement technique for fetal retrovesical interspace? A transverse image of fetal pelvis should be taken at the level of the umbilical arteries or visualized in a cross section on either side of midpoint of the bladder side walls. Color imaging is helpful to ensure an accurate level. If the umbilical arteries are noted at the anterior aspect of the bladder, the level is too high. But if the umbilical arteries are at the posterior aspect of the bladder, the level is too low. And if the umbilical arteries are in a longitudinal section, then there is a craniocaudal tilt. After magnification, the distance between the posterior wall of the fetal bladder and the anterior wall of the rectum is measured. The interface with the bladder is concave, convex, or flat. A concave interface is defined as a concave indentation of the posterior aspect of the bladder with respect to the interface of the other structures posterior to the bladder. A convex interface is defined as a convex contour of the posterior aspect of the bladder with respect to the structures posterior to the bladder. These images were taken from this article. This image related to a female fetus at 25 weeks gestation. We can see here the biconvex uterus and the echogenic line of the endometrium clearly. Here, please note the concave indentation of the posterior aspect of the bladder by the uterus. And this image is related to a male pelvis at 25 weeks gestation. Note the slightly convex contour of the bladder with respect to the posterior structure. Of course, taking such images in the prone position of the fetus is very time-consuming and difficult, especially in overweight women. These images are taken from the patients of our center. We can see here the biconvex uterus, the echogenic endometrium in the center. Here is rectum. We must measure the distance between the posterior wall of the bladder and anterior wall of the rectum. This image related to a male fetus. Of course, here is not the biconvex uterus, but we can see here the rectum, the posterior wall of the bladder, and the anterior wall of the rectum. As you can compare between these two images, the distance in female fetuses is higher in comparison with male fetus. The presence of a concave interface with the bladder was found to be highly predictive of a female fetus, with 98% of all concave interfaces occurring in female fetuses, and about 93% of all other interfaces, including convex or flat interface, occurring in male fetuses. What is the role of three-dimensional ultrasound in fetal sex determination? 3D ultrasound is a lethal diagnostic value in determining fetal sex in the first and early second trimester, especially when using the rendering 3D image reconstruction mode. Moreover, it can be misleading. This study concluded that surface rendering was of minimal value for gender diagnosis before 12 weeks of gestation. In the second and third trimester, 3D depiction of the external genitalia using the rendering mode can demonstrate the fetal sex more clearly. In some cases in which congenital malformation of the external genitalia is suspected, 3D ultrasound may have diagnostic value, as will be discussed in the next videos. What is the pitfall in sonographic fetal sex determination during the second and third trimesters? In fetuses without congenital malformation of the external genitalia, diagnosis of fetal sex based on the above-mentioned sonographic findings are accurate in 90 to 100% of cases. However, fetuses with malformations of the external genitalia represent diagnostic talent. Abnormalities of the genitalia should also be suspected whenever a mismatch is found between the sonographic fetal sex and karyotypic fetal sex. Clues to presence of congenital malformations of the external genitalia which causing pitfalls in sonographic fetal sex determination include non-visualization of the fetal bladder, diagnosis of female genitalia at early gestation based on caudal orientation of the genital tubercle, followed at a later time by observation of a male genitalia. Marked phallic size discrepancy for gestational age, curvature of the phallus, scrotal phallus malposition, non-descended testis in the third trimester, absence of phallic, labial, or scrotal structures. Now, please pay attention to these final teaching points. Unlike first trimester sex determination based mainly on the visualization of the angle of the genital tubercle, second trimester fetal sex determination is based on actual visualization of the penis and scrotum in males and the labia majora and minora in females. The anogenital distance has the potential to aid in the early identifications or understanding of pathogenesis of genitalia development, polycystic ovary syndrome, anorectal and male genitalia malformation, and neurodevelopmental outcomes associated with elevated prenatal steroids such as autism. Of course, in normal fetuses, fetal scrotum and penis size are not needed to determine the fetal sex, but in cases of ambiguous genitalia, these items in nomograms will be very helpful. Measuring fetal retrovesical interspace allowed us to determine fetal sex correctly in about 99% of female fetuses and 100% of male fetuses between 14 and 40 weeks of gestation. Now, I suggest two others of my videos that are close to this video in terms of matter. And thank you for your attention.